Right. So we're going kind of early, or actually 1 minute late. Sorry for the delay. No. So tonight's not a super long chapter, but it is behavioral emergencies. We do have a lot of these that we will have to deal with a lot pretty regular in your career. You may not have had to deal with them in the past, or you may have had to. So that's something that we'll. It's a learning thing. We'll have to learn. It's a process on the learning here on how to deal with certain types of behavioral emergencies. All right, so we know here it's the same thing every single time. It's over and over, but that's it. So, senior psychiatric, what we want you to do is you want to recognize which ones pose a risk for each of us, potentially other patients. What are some of the basic principles of mental health system? I think our entire entire medical history, I mean, our mental health system is broke. It's destroyed, and that's just due to funding. I don't mean particular, states or regions and like that. Just the funding was removed from the mental health division and has created a huge impact on that. How you manage and assess patients that's had acute issues or fundamental problems. So that's just how we're going to do that. Hey guys, hang on 2 seconds for me. No problem. Sorry guys, my dad surprised me right in the middle of it. So bye,
Hi,
love you.
Dad.
No, say hey, students are saying hi. He can't hear. I guess he needs to turn his hearing aid up. But anyway, so what we want to do is how to recognize suicide, how to assess it, and basically how to talk to them. I mean, at the same time, I don't want to say how to talk to them. They're just humans like everything else. But in that mindset, we have to understand that they think that everything in the world is wrong, that the problems are there, and they just can't be fixed. So, and just how to recognize that. Let's talk about agitation, delirium, and things like that. So, those are also different states that we have to worry about, states of mind that we have to be concerned about. Um, so EMTs, we know that we're going to take care of these. These behavioral crises are on the daily. I mean, hell, I got to wake up my daughter every morning at 5:30 to get on the bus. That is a behavioral emergency because I don't know what demon is in my child to do that. So I have to deal with it every day.
I imagine it's the same demon in my child.
I don't know what it is, bro. It is like who has possessed this child. So that being said, is we all deal with it. We all have these concerns and issues. We have to take special considerations for dealing with them. And I'm talking for our children in the morning to just our general overall patient care of the mental. I hate to say mental challenge because I know that kind of goes into our uh, special needs adults and children's, but just it's how to take care of them during their middle mental crisis. Let's put it that way. And it may be due to some mind altering substances. We all have stress. We deal with stress differently. Um, and some people that are just overwhelmed with stress in life just can't see any way out. I know death is a big cause of one. Let's see, not say marriage, but that can be a stressor. And then also divorce. You loss of a loved one. It can be a huge mental stress on some things. Um, let's see. Most people some point experience mental crisis, and we all do experience them in our lives in different ways. So that being said, is how we handle them is is what we need to make sure is moving forward that we're all healthy and we're taken care of in a very healthy manner. So when people actually reach out for assistance, that's their cry for help. And it's how we address those issues that we get them to the right place. Um, what it says there, don't jump to a conclusion that a patient is always mentally ill. They may be going through a challenging time. Healthy individuals, they can also go through acute and temporary mental health disorders. It's not something that's it's chronic. It may just be an acute issue that pops up because of a life-altering event. Um, Financial loss. I mean, I say financial gain too, because can cause a lot of stressors and create just you know, just releases a lot of havoc. Is what I'm trying to say. That I don't know why I couldn't get it out. So here is the most common misconceptions: that if you feel bad or depressed, you must feel sick. Um, I'll pick on my wife. She's not here, so I can say it. My wife, she does have anxiety. Now, granted, she's not crazy as all get out, but she does take some medications for that, and it helps. Now we see that as being more and more throughout these through our times right now as people feel the anxiety. I know during COVID and being locked down, a lot of people suffered from depression and anxiety. Um, I say the same thing for my kids. My oldest suffers. Oh, sorry, y'all. My cat decided to change the screen. Um, th- he has attention deficit, and so does my middle child. And it's like, well, why? Why is this here versus when I was growing up? And I blame a lot of that on the foods, just because they are attention deficit and they take medications. I mean, I would never say my child's sick. I mean, it's just that they have a curve that, but why? My question is why are these here all of a sudden to all the majority of the children nowadays versus what's the difference in the gap versus when we were children? Um, so we know some reasons for depressed. We already talked about that: divorce, loss of a job, death of a relative or a friend, and those are just normal acute crisis reactions. So it's not like we said, they're not sick. They just have normal reactions to normal things that happen. You cannot go through life without dealing with death. You are going to deal with it. Um, I guarantee you, everybody sitting in here has had either personal experience or knows somebody that's been through divorce. So those reactions are going to be there. Like since I've dealt with it myself, and knowing in the medical background, I related to going through divorce as the 5 stages of death. Those are not like no pun intended, don't get me wrong, but it's your anger, you you kind of compromise, you go through the blaming game, you do acceptance, and so there's five. Hello, everybody there?
Hello.
I don't know what happened. Like my screen flashed, everything flashed. So what can y'all see?
Your face. It's a sign.
Your
Tonight's
face.
the first NFL game of the season. It's time to end class.
Hello, is anybody there?
Yes, sir. We're here.
I don't know what happened. It's like it just went poof. What can y'all see right now?
We just see
Your
your
face.
face right now on gallery view,
All right,
but we
well,
don't
stand
see
by.
the PowerPoint anymore.
Let me see what happened. I don't know what happened there, y'all. All right, is that better?
Yeah, we can see it now. I can.
Good deal. Well, seeing as how there's only 7 people in here, I'm gonna take your. That's pretty high voice.
Yeah,
All
we
right,
can see.
so. All right. So again, sorry, I don't know what happened there. That was new to me. It said everything was working fine, but obviously it wasn't. All right, so if we've dealt through death, we're going to deal with that. The 5 stages of death, you're going to go through that with death of a loved one or a close family member, and the same thing with divorce. You're going to see those same stages. You may not see every single stage. I know when my mom passed, um, I had just a big gap that was created. I wasn't anger. I was glad my mom was not in pain anymore. I don't think I was, compromised at all. Um, but you deal with them differently. You have these things that you just handle it all differently. So you'll see those, all right? So, all right, some people believe that all individuals with mental health unmanageable. That is so not true. Now, you may have severe crisis that you go through and deal with. That may be. You may have somebody that is untreated that has manic disorders when they aren't on their medications regular. Or you have those that are on a medication and is managed very well, and due to a life event that they may have not able to pay for their medicine. So, but not every person that you come across is violent or they're going to be, harmful. Let's see, only small percentage of the people with mental health problems fall into these categories. You may be exposed to higher proportion of violent patients because they're seeing people who are, by definition, considered to be having behavioral crisis. Communication is the key. In some cases, patients will de-escalate when a level of trust is established. I've done this a lot. Like specifically, say I like working male female trucks. There's a there's an excellent time that there's a female on the truck. It's very hard to work double male trucks, in my personal opinion, because if you come across, say, a female that may have been sexually assaulted, that is very hard for her to gain that trust when you have double males trying to take care of her. So at the same time as that's why I like females, I probably only work male female trucks. Is because we need to build that bond. Maybe they're not built. Maybe that bond is not built with me, and I'm the paramedic to be there, and that's okay. If the basic is there, advanced or whatever, maybe it is another paramedic and can build that bond. Bro, I don't care. You can have this patient. Get in the back. I'll drive you to the hospital, because it's about the betterment of the patient to do what needs to be done. Now, if it's life threatening, they're in and out of consciousness, I'm not really worried about it. I don't care. We're going to do what we got to do. So although you cannot determine what has caused a person's crisis, you may be able to tell what's going to happen by their manner, by their presence. What do they physically look like? As in, are they sitting there shaking back and forth? They're jerking. Just their overall demeanor is what's going to tell you, just going to be able to predict what's going to happen. If they are all of a sudden talking and then they get super quiet and you're like, uh-oh. My question first is, what I got on my face? What's on my face? Is something there? But you know that you may be able to start predicting these things. Behavioral crisis is something you cannot see initially, but you're going to be able to pick up by their response. What's going on? Let's see. Over time, people have learned to adapt to various situations in daily life, including stress. We have what are the animals, the working dogs, I like the specifically like the medical dogs. A friend of ours, she has sugar problems. Well, the dog will get her attention and it's trained. She puts her hand out. If the dog puts his foot on top of her hand, her sugar's high. If it's on low, the dog puts his hand on that. Now, those are cool, man. I mean, like, we can get those. You have your stressed animals. See, I've always said, I don't want me a PTSD monkey. So when I get pissed off, that thing can sling shit around. And it's not my fault. It's just part of the monkey. Maybe when I'm mad, I can teach them to do that. So that's just my little pun. But we have these ways and abilities to allow people that in normal situations would feel as an outcast, that we don't outcast them, that they're able to function You know, some kids on certain spectrums don't do loud noises, but they're okay with people, so they wear headphones out, the noise canceling headphones. That's a great. Well, I mean, technology has helped us out a lot. A really good friend of mine, his child is nonverbal, but he communicates through an iPad, and he has learned that. He does not warrant any physical contact, and he will get violent, but he communicates with you very well, carries on conversations, and he don't ever look at the iPad, but he pushes the right buttons. I'm assuming he makes great sentences, but I mean, who knows? The change in behavior may consider it inappropriate or not normal because that's who's calling you. This dude's losing his mind. He's like throwing things around. Well, maybe in the patient's mind that's okay, but in general society, that's not okay. A lady at Taco Bell laughed at your shit doing. Oh, sorry, my bad. Whoops. But it's true. I mean, think about it. How cool would that monkey be? That would be amazing.
That would be pretty cool.
So would you get in trouble though? I mean, I know it's not healthy and it's not sanitary, but I mean, you could literally blame somebody else for him responding to your feelings. That would be super cool. All right. So anyway, get off my topic there. What the book says is a behavioral crisis is, so obviously I'm having internet trouble, y'all. I don't know. My internet just said internet slow. So if there's an issue, I'm sorry. If something happens, y'all just message me real quick on Discord and just give me just a minute. So behavioral crisis includes patients of all ages who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or others. Most of the time, EMS is called at this point because people are like, "Oh my God, this patient needs help. Let's call EMS." Well, I jokingly say, "Great, cool, we'll come help you," but you realize we have zero things to defend ourselves and or to defend against you. I know cops are not taught how to handle mentally ill patients. Some states push that very heavily. Some states do not. I'm in a state to where they give you like 8 hours of training while you go through the law enforcement academy. Then after that, you learn on the streets. Well, we're times are changing. Maybe we need more on de-escalations and stuff like that. So, but de-escalation isn't tough. That's a whole nother topic. Let's change that one. All right. So let's just say, usually if an abnormal or disrupting pattern or behavior lasts for a month or more, is a matter of concern from mental health standpoint. When behavior health emergencies arise, the patient may show agitation or violence, may become a threat to themselves or others. So when you hear let's see, like if I threaten suicide, it's either HI or SI. So it's homicidal ideations or suicidal ideations. You can use those abbreviations when you're given a report to the hospital or by radio. You know, be advised, patient state in HISI thoughts. We are en route to your facility, and you can kind of quit beating around the bush, because what that does is it lets the hospital know to be on standby, be on guard, because now this patient may warrant to be restrained. And okay, that's fine, but we don't need to walk in there and sedate them and restrain them, because maybe we've built that rapport with them. And on the way to the hospital, I'm like, okay, Mr. Fred, now listen to me. I need you to look at me right here. When we get there, there's going to be a police officer. He's going to check your pockets. He's just making sure you didn't bring any grenades or flamethrowers. And if you've built a good enough rapport, I've had before where they laugh or they look at you and be like, well, I didn't bring them. So, or then you have ones that just don't say anything to you. But versus in letting them know in advance, we're also going to have another nurse show up. And this nurse is going to do such and such, such and such. And at some point, you're going to have to talk to them if you want some help. So what you can do is build that relationship so there's not the agitation there. or the violence that builds up from them just saying, F all y'all, I don't want to do it. I'm going to show you that well, eventually they'll win because they're going to tie you, like calf tie you down with your heels around your ankles. So be cautious of that. The more you can help inform the mental crisis, the better outcome you're going to get. And obviously we have to protect others, even though that we are going to provide. Sorry, my gosh. Even though we're going there to provide assistance, we need to protect others. We need to be very cautious on what we do, how we do, to keep others from getting harmed. It is also falls on our job description for that. All right, so the magnitude of mental health disorders, there's so many out there that it's crazy, and it seems like they just get added on every year. But according to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. Just think about when you hear tens of millions. That's close to half of your population that have some sort of mental disorders. Now, I don't know if y'all know this, or if you care to know, it's just a side note, Chris Wally's thoughts here. If you ever get admitted to a mental institution in the state of Mississippi, you're never allowed to own a firearm again. Now, crazy about that is because the reason why I know that is my mom suffered from Crohn's disease. My mom had spent 376 consecutive days in a hospital in Vicksburg, Mississippi. Like, the school bus would let me off at the hospital. I would bounce around up in there. I knew the hospital better than some of the people that worked there. But what was bad about this is one time my mom was being moved rooms and was put on the psych ward for 23 hours until the room could be cleared, and they had to do something in the room. That it was a piece of equipment, but because they changed her status and rooms, that bumped her from ever being able to own a firearm again in the state of Mississippi. Now that's crazy. Yes, we fought that for years and eventually we got around it, but it took us 10 years to get that fixed. Now, I know that may be minute, but that's just something you think about. Now, it's not saying that this psychotic person or psychotic episode is ever gonna like not have a weapon, because not saying that they're in their right mind or that they may acquire it. They may just find it. Let's see, psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functions. Anxiety disorders are among the most common health disorders. Generalized anxiety disorders, panic disorders, social and other phobias, PTSD, obsessive compulsive disorder. Now, let me give you some more Chris Wally's on PTSD. I think that term is very overused. I think it's initially started with the military coming back and they weren't sure what to use. So they used a different term prior to that, but they started talking about it as a post-traumatic disorder. Well, then they started adding stress in there, because I remember in paperwork you used to see PTD. Now they have PTSD. Well, then the doctor world was like, oh, well, there's already a classification. Let's just use that for the general public. So I literally have heard, and I know, and the reason why I can say this is I've read it with my own eyes, that a lady experienced a traumatic event by watching a dog being beaten. Now, granted, I'm not saying that's okay. By no means that is okay for animal cruelty. But she is now 78% mentally disabled and gets paid by the federal government because she has PTSD of that. You got to be kidding me. So some of these terms are well overused, or the system is broken itself. So just because they do have these diagnoses, I know multiple buddies of mine that's come back from the Middle East, that were diagnosed with PTSD, and they're 98% disabled through the military and work harder than I thought I could ever work. When I come back, when I had two being blown up twice, they tried to classify me with PTSD of loud noises. I was like, well, maybe he thinks because I was shot at for so long and blown up twice. But I refuse to allow that on my on my medical documentations. Joshua, I agree with you. PTSD because you can't seem to win the lottery. So I think that's crappy. They may not like you, and I think that should be a lawsuit. Everybody's suing for everything now. Matter of fact, I heard a lawsuit on the Bobby Bones show the other day. So this potato company has created onion ring potato chips. He's suing them because he was misled because there was not real onions in there. I'm like, and he'll probably win because it wasn't put on the bag that they didn't have it in there. It's retarded. Matter of fact, do y'all know that Winnebago 18 years ago did not have in their manual that it is unsafe to leave the steering wheel or the driver's seat while the vehicle is in motion? Because there is a man that travels the world now that sued Winnebago because it did not say that in his manual, and he got up and walked to use the restroom in his Winnebago and wrecked, and so much like it's caused unsorts of godly damage to them that they write this man an ungodly check every month, and he gets a new Winnebago every year. What is wrong with it? That's common sense. Don't get up from a moving vehicle. Red Bull got sued a couple. Yeah, it's so crazy because there's not a red. It didn't come out of a Red Bull. I'm sure it's nuts. So when I say, let me back on my paperwork now. When it says that some of these disorders are overused, be cautious when you interview somebody and they tell you that they have these particular orders. So let's think about that. The U.S. health system provides many levels of assistance, which is not true anymore. And the reason why is because the mental health fund has been decreased drastically. Look at your own state's mental health issues. Look at how many people worked for your state health agency in 2015 doing mental health versus how many work now. I guarantee you that number is not even a third that's still in the same area because that's cut down so much. Let's see some of the most. Go ahead, please.
No, I was just going to say a quick story from work the other day. We had to do a patient transport for a child here in Alabama, and this kid was diagnosed with PTSD from school because something had happened, and they sent him to a geriatric ward hospital, to the geriatric ward in a hospital to get treatment.
Like, so overused. I mean,
the kid was 5 years old.
Like, really, that's crazy. But and by no means, I don't blame the child. Okay, so don't get me that, and I don't blame the individuals that did these classifications. I blame the system. They're like, oh, we'll just say it's PTSD, or we'll just say blah. Well, it's not that easy. There's so much else out there. You're right, Caesar. That's 100% why. It's money. That's the same thing as everybody that has died here lately has died of COVID. There's a shooting in my state capital. I think we're the second dangerous capital in the world right now. The dude was shot 16 times. He died of COVID. That's called lead poisoning in my book. So anyway, so people are put in categories. All right. So let's see. So some of the people that have schizophrenia, bipolar, do require more treatment. They require psychiatric help. They prescribe medication. So, and those are the ones that I say, yes, they need help. Now, how that came along, I don't understand. I do not know what potential cause has created that. But at the same time, it's some of those that just, it is what it is, boys. That's the best I can tell you. Most psychological disorders can be handled through outpatient visits. Some patients do require hospitalizations, and they do have special behavioral units. Like you said, Caesar was pointing out, that they have the geriatric units. So majority of those are older than 65 that go to those. Well, now we know that there's a 0.1 that's younger than that, but they go there for specialized assistance. They may have certain types of care that is provided specifically in there. They may have, they try to help wing them to being back to better care. But and then you have your like your state medical facilities, like your state mental hospitals that treat your severe ones. And they have some that have created like Masteria, like Luke Whittam, and I'm sure y'all remember the very first school shooting happened in Pearl, Mississippi. That is, I can get to that school in 6 minutes. That's right down the road. I remember when this happened. Luke Whittam shot both of his parents, dumped them in my town, and then turned around and went to the school and had a couple of shootings. He's locked away in our state mental facility. I can tell you because I know one of his physicians. Luke Whittam is a very smart individual, very, very, very smart. He's gone through. I mean, he's done online. He has his PhD now. He's been there so long into these specialized behavioral facilities that they had to do something for him. They had to help him. Now, granted, is he gonna be able to get and practice PhD? But no, he has the paperwork and documentation that says he is. So, next, come on, computer. All right, behavioral disorders. They do have several underlying issues. Some, like we said, may be schizophrenia. You could have situational stress. Prime example, I don't do loud noises. I shoot. I love to go shooting, but at the same time, as if I'm not, I can't do fireworks. One of the things that triggers me is the dentist, the dropping of the little tools on the metal tray. I can't handle I go nuts. But I spoke with my doctor about that. So when I do go in and get my teeth cleaned and all that, I wear my shooting headphones and then I wear earplugs also. And they just move my mouth how they need to. And they lay I say a tissue, but it's a padding when they put the tools there. And it's something that we've worked on. And it's not that I am a little crazy. I mean, I guess so. But it's just something that triggers me. It's a trigger. So people have triggers that you're not aware of. Maybe if you're around and you start clapping, somebody can have a mental because that's something that it's a trigger for them. Chemical problems. We know that alcohol can be such a huge issue. Coming off of or going to the DTs because they can't get it. You may have the electrolyte. Oh, Jesus, my cat is talking to y'all too. So some of your biological disturbances, when we talk about electrolytes, we may be speaking more towards like the dehydration or they just don't have enough, and these mental disorders just can emphasize on that. And that's where some of the problems key in is like DTs for alcohol. Man, I've seen people have DTs for heroin, tobacco, cocaine. It's nuts on what just they do for the imbalances of the body that when you try to remove it on how bad it is. So we're not by no means is anybody asking you to diagnose any of your patients. Any patient that you ever come across, nobody's trying to say, well, he has acidosis. Well, no, we want you to be able to recognize some of it. And that may be through education. That may be just in learning, like I've seen this exact thing happen before. I wonder if it's this, and then going back to the hospital later and be like, hey, when we brought in Fred, what was his diagnosis or what did y'all treat him for? And be like, they kind of look at you like, well, I want to know. Yeah, we brought him in and took care of him. But my question is, I just want to learn a little bit. If a little bit more I can learn, the better off. So if I see it again, I know which way to go. So being able to diagnose something, that is an MD's issue. That's their problem. That's their worry. It's not ours. I could care less if they treated him because and turn around and gave him a diagnosis of gangrene. I got him where he needed to be. I did the best that I could. I didn't cause any harm, and we moved on. Some of the organic issues, you may have organic brain issues that affect hair. It's a temporary or permanent dysfunction caused by brain disturbance in the physical or psychological function of a brain. You may have a sudden illness. You may have a TBI, seizures, drug or alcohol abuse, overdose, or withdrawals, diseases of the brain such as Alzheimer's disease and meningitis. Um, I've actually treated a patient with meningitis one time, and I actually recognized it. I was able to figure it out. And there's nothing I could do in the field, but when I got to the facility, I was like, Doc, I really think this is like meningitis. Listen to him, do your history on him, and tell me what you think. Well, later on, I come back and the doc was like, "Oh, you're right. That's what it was." And I felt like $1,000,000 that night, but I didn't get to pay for it. But it was just because I've seen it before, and I was like, this is just weird. Like, this sounds too much like I've seen it before. So I was able to learn. I got some experience out of it. So you may have some organic issues. You would talk about hypoglycemia, hypoxia, impaired cerebral blood flow, hypothermia or hypothermia. In the absence of a physical cause, altered mental status may be an indicator or a psychiatric disorder such as bipolar disorder. Somebody tell me what hypoxia is.
Isn't that absence of oxygen in the tissues or membranes or whatever?
So you remember what hypo stands for, right?
Yeah, so hypo would be like low oxygen.
Correct. There you go. So perfect. And then your hypoglycemia, I mean, that's low sugar. But if you're like, hey, are you hypoglycemic? And people look at you like, what's she talking about? Speak to them. Hey, hold on 2 seconds for me, y'all, real quick. Sorry, y'all. So you want to know if they got high sugar, low sugar. You don't want to just, again, we've said this before, you don't want to talk to a patient or a bystander and you over talk them because they're gonna be like, well, why are you trying to talk over my head? You make me feel stupid. So we don't want to do that. We just want to make sure that we can talk to them on a level that they get it. Functional disorders. So you have your psychological disorders or impaired body functions. Um, Examples, you have schizophrenia, anxiety conditions, or depression. Those are particularly hard to deal with because you don't know that particular person's trigger for the schizophrenia. Depression, most of the time, if we get called, it's going to be due to severe depression. So think about that. So how do we handle that in the EMS setting? Well, there's nothing that we have or do or can do that will fix that. We just have to go off of it. We have to, try to speak with them. We try to talk to them. We try to let them understand and roll from there. So anxiety, that's at the same time. There's no medication that we carry on an ambulance that can fix these conditions. We just try to get them to where they need to be in a promptly manner. So what do? How are we going to fix this? Well, we don't ever want to stand over a patient and talk down to them. We want to try our best to get down to their level, but at the same time in a safely manner. If it's not safe for us to be as close as they are in this picture, but it looks like they're having like this guy has something else besides potentially what's going on because this guy's in a full gown, face shield, and glove, like he's ready to have surgery. So, but you want to try to talk at the same plane as them, face to face. You don't want to talk above them. You don't want to try to get below them either because if they lunge towards you, you're not going to have time to react. Now I say that, but if you have some experience in hand jujitsu and stuff like that, that may be your chi. You may be like, oh, good day at work. Patient tried to attack me and I put him in an armbar. But be cautious. be very careful on where you position yourself when you deal with somebody that's having these behavioral emergencies, because they can backfire on us very quick. So scene safety, we understand that scene safety is the most important. I say yes, it is always important to have law enforcement in this timely, and that's because they're the ones that carry the tools, the metal cuffs, the this and that. But tell them, hey, it's okay for you to stand in the yard. Let me walk up on them, please. Let me get close to them. Allow me to try to speak to them, because a lot of people see police as, oh, they're going to arrest me and take me to jail. Well, that's not every single officer, and that's not every single call warrants us to arrest them. Every single call we go to in EMS doesn't warrant us to take them to the hospital. Maybe we can fix it there, take them to emergent care, something like that. So um, allow assistance, police, fire, whomever, to come help you. But you may try to say like, hey, let me see if I can work this before you get up in there, because I'm afraid that your presence may trigger them, but I need some backup. So just, if you know your cops in your area, the better off you'll be when you start getting to that point. Patient's behavior appears to be out of the normal for the circumstance. Like, they called us for respiratory illness, but this dude is super agitated. Like, he's being, like, every little thing starting to trigger him off. I don't know what's up with this guy. Pay attention to those signs. Take appropriate standards, precautions, and request additional resources. Ask for them early. If you need, two officers on scene, be very specific on what you ask for, but ask for it as early as you can, because at the same time as the officers have a response time. So if we can give them, the heads up and that response to get there to be prepared, the safer we can be. Um, Mechanism of injury. What warranted us to come out? Was it because of an injury or an illness? Did they happen to do something? Did they take something? Did they find anything? I mean, like, what medical condition do they have that warrants us to treat them? That it's hard, because sometimes we just don't know, and it's okay. I showed my butt earlier today, and here's why. It's okay for people in the medical field to say, you know what, I just don't know. Don't lie about it, but just say, hey, I'm bringing them here to this facility. I can't tell you what their chief complaint is, but it doesn't appear to be normal. And when you get there, just tell the medical staff what happened. This warranted this because of this, and it just didn't seem right. I asked them if I could take them to a hospital, and they got in the ambulance. So guess what? Here we are, bro. Now, granted, I'm sure you'll hear some crap from the ER staff, but guess what? They're gonna fuss at you, or they're gonna fuss at somebody else. Forming a general impression. What we've talked about this and all the other ones. What do you see? What do you observe? What's the house, the scene? What's the overall, I say, the health of the scene? And what's the conditions look like? Are they in a rundown place? Are they in a hotel or an alley? What do I see, and what am I thinking in my head already what this can be? We've had some issues down here before that I remember us dealing with as an officer. I actually was an initial officer. A young lady multiple times had stated she was raped. It appeared that way. It had every writing on the wall, and she had had relations with a fella. But what had happened is she had suffered from a mental disorder, and after every single time that she had relations, she always claimed that. She thought in her head that's what will happen. That's what's going on. So it triggers things. You have to be careful about that. When you say certain things about mental health, or like, I don't feel comfortable, blah blah blah. certain triggers are going to be done in the mental health system that you can't help but say something. If you see it, you have to report it. So that's like I tell people offshore, be cautious how many times you sneeze around me, because if you keep sneezing like that, I'm gonna have to take you upstairs and treat you, or call for potential exposure to COVID. And jokingly say that, but people, they get it because they know, uh-oh, maybe that's a trigger that I may not want to do. With mental health, it's the same way. Is we don't want to know what triggers these patients because we may see something or experience something that we don't want to see, but it potentially can allow us to see very bad things that are or will happen. Airway and breathing. Are they breathing adequately enough to support life? Are they maintaining their own airway? Are they laughing, talking, and breathing, but complain that they can't catch their breath? Use your tools. If your tools are there and present and working, ask them, hey, sir, is there any way that I can put this little probe on your finger and check your blood pressure? As soon as I put it on, I'll back away. I'll give you your space. Sir, it's over. Is there any way that I can walk over there and remove that? Get their permission. Explain things. Those are your tools to build a good patient assessment, a patient treatment plan. Those are all your tools to help work on that. So with that, that you need to know those things on the get-go. How do you talk to them? How do you work on there? What do I got to say to get this person to allow me to do this or that? Sometimes with certain mental crisis patients, you're not going to be able to check their pulse, rate, quality, and rhythm. They may not want you to touch them. Your best bet may just be in saying, unable to check vitals due to patient's agitation, and stated that they wouldn't allow somebody close to them. If the patient says, I don't want you to touch me, I'll put that just like that in my report. I had a guy one time, I'm sure y'all heard so far, I'm very good on being very upfront and honest. He was crazy. God, he was crazy. I said, sir, I just need your name for report. He said, MFer. Well, I said, is that first or is that last? He said, both. So guess what his name was on my report? I asked it, what he told me. So it's what I put down. Now, granted, I didn't take him anywhere, but sometimes they don't want you to talk to you. They don't need you to know around them. You got to do what you got to do. But you can assess their, their skin color. You can't check their temperature or cap refill, but you can say, patients, appeared to have redness of the skin. Patient appeared to be pale. Things like that. You can note those things. Now, you're not going to walk over and be like, patient felt warm to the touch. Well, just because you can't get too close with some of these. But if you did it, you need to document that so you can move on to help this patient even better, more. Transport decisions, if they allow you to get this warranted and done, some patients at this point will have to be force your hand to call med control, and either after you explain to med control and warrant what's happening, the med control doctor may be like, yeah, go ahead and transport them and bring them to my facility. I'll be waiting. Or yes, that patient needs to be transported to a psychiatric, location. And then when you transport, per Dr. Hill's, patient was to be transported. Patient is restrained, via whatever. Just don't ever use duct tape. That doesn't ever turn out good for you in the long run, because you get in trouble for it. So just letting y'all know. So on the transportation, stay and play or let them go. It's critical and all that. And don't forget, if the patient makes a decision, I always allow people, if they warrant the decisions on what hospital they want to go. And then once I do an assessment on them, or I check this or that, If it needs to go to another facility, and it may be because it's a trauma or specific to cardiac, I may be like, well, you made a really good decision, but since I'm now looking at this, this, and this, you're going to go to such and such hospital because that is the better place for treatment for you. Now, the patients cannot be happy sometimes, and it is what it is, but call your supervisor. Let the patient fuss at the supervisor about it. It's not your problem. History, you can get a good assessment from these patients sometimes if they're talking, but if not, rely on bystanders or a care provider. Um, Building a history on a non-verbal patient is going to be hard. Um, and you may just be able to have to note, hey, unable to gain any more patient information due to lack of response. It's okay. Here's some of your other questions. Now, be cautious how you ask them. Let's see here. Is the patient withdrawn or detached, hostile, friendly, happy, or depressed? I'm not gonna remember to write all that in there. I'll just put patient stated he didn't want to talk to me, but would get an ambulance to go to the hospital. Okay, there's my question. I'm done. But I don't know what you want me to, I don't know. He don't want to talk to me. So do I want to keep agitating him and make it worse or just roll with the flow? Not my problem. So I'll leave it how it is. When we start our secondary assessment, if they will allow you and you've built that rapport, get up in there, check on them again. Hey man, I just wanted to make sure everything's good before we get to the hospital. Has anything changed? Are you hurting anywhere? You have any trouble breathing? Lost taste, sense, or smell? Things like that will also build the rapport with these patients. So they may be able to be more open to you. And while you're going, you're like, actually, I'm having a little trouble with my back, and these patients build once they understand that they can trust you, they open up a whole lot more. It just may take time. The physical exam, look for their, now you don't want to be staring at them, but if their facial expressions change, adjust, or monitor in any form or fashion, note that. If you do something that appears to cause pain, you can be like, sir, hang on, before I go any further. You look like this hurts you. Can you tell me where it hurt and describe that pain to me? Well, now you realize and you're relaying to the patient that you care. You're not just a person that's going to sit there and ask all these questions. You care about them, so they may be more lenient to open up and tell you some more things that are going on with them. Be cautious of that blank stare and that rapid moving. I know how it says it may be from the CNS or dysfunction. A lot of people think about seizures, but just be cautious because that may be a sign saying that the patient it's soon to react to something. So be cautious on that. Transport decisions, you may have to have somebody assist and ride with you. A lot of police departments will follow behind you, so you'll be able to get your butt kicked for the first couple of seconds until they open the back doors and help you. Or they may send a fireman along with you. Don't take the smallest new guy on the department if you think that there's going to be an issue. Take one that's been there for a hot minute. And the reason why I say that is because they know what they can and can't do. You can't lead them down a wrong direction. So if something does go sour and you all end up in court, they're not going to end up hurting you because they're like, oh, I was just doing what the paramedic told me to do. So be cautious about that because they will burn you at the same time. Never ever let your guard down. Now, and I'm gonna say reassessment and that on something with the behavioral crisis, that's gonna have to be done all the time because you need to be monitoring them as much as possible and seeing if anything has changed. You if possible and you do restrain them, you treat them as a critical patient at that point because you've taken away their movement, you've restricted their breathing. And the reason why I say that, it's not like I've tied something over their chest, but you have restricted for them to move into a better position to gain oxygen. So if you do restrain somebody and you probably need to put them on a low dose of oxygen because it's just more helpful. So be cautious on that when you go to restrain somebody. And if you do restrain them, remember to check on them very, very often. Interventions, if you're able to do something, is just like a trauma patient or another medical patient. If you did it, you have to reassess it, and then you document what you did. If you have to restrain somebody, 90% of your agencies require you to document a medical provider's name that gave you the orders for physical restraint. Now, if your paramedic gets orders for a chemical restraint, which would be by medication, that same order has to be documented in the PCR. So that way that you bring in this limpless, motionless body, that you're not going to get in trouble for it. Communication and documentations. Again, give the receiving hospital advance notice as possible. Let them know. Hold on a second. Let them know what's going on. Be advised, patient is restrained. He's physically restrained unless your paramedic has orders for chemical. It may be something that you may have to call in a report for your paramedic because their hands are full. You can say, patient is chemically restrained at this time. The medic is unable to give a full assessment, but patient is blah, 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 whatever your paramedic's telling you to give them relate to the hospital. Make sure you do that. You need to always document what type of restraints because a lot of your agencies have gone to soft physical restraints to where there's one on each extremity. And then some agencies still allow you to use a sheet wrapped around the chest. And what that does is help hold the torso down from moving around all over the body. I mean, moving around as you're trying to physically restrain them. So document that specifically. Psychosis is a state of delusion, which the person is out of touch with reality. There's some signs and symptoms right there, or some causes that may have done that. Affected people live in their own reality of ideas and feelings at this point because their thought process is nobody else's problems, concerns, or issues affect them. Their emergency is the most important, and that's what's wrong. You need to assist them and help them, and that's the only thought process. Let's see, I'm gonna finish these 5 slides and we'll take a break. Schizophrenia is a complex disorder that is not easily defined or treated because it's something that is a chemical restraint that they have to look for. So it's most of the time this does not set in until they're an adult, but at the same time is they may have childhood. They may diagnose the child with a different type of disorder, but when they get older, they'll be turned around and diagnosed with schizophrenia because you don't really see that a lot in children. Even though like everybody knows, oh, crazy Karen. There's a crazy Karen that we all know, and you may be like, she just crazy. Well, there may be a missed underlying dosage, a diagnosis. May just be crazy Karen. But again, just be careful. You may have some genetic issues there, psychological and social influences. They may have had that one bad round of drugs that was overlaced with fentanyl and it just them up. So, and that may just have caused the mental disorder. So, the issue there, that's all chemically induced. That happened prior to our care, and we weren't able to do anything about it. Symptoms of schizophrenia are right there. I'm gonna let y'all read that second. I'm gonna take a quick drink of Sorry, I couldn't unmute. My mouse disappeared. And then some guidelines for dealing with psych patients. These are not guidelines; they're just good ideas because your agency is the one that's going to set that guideline in place for you to be known how to take care of these patients. Determine which situation dangerous. Well, obviously, that's probably going to be obvious when you get there and be like, yeah, this dude's nuts. He's certifiably. We got to be cautious about that. Let's get some help out here. Make sure they know who you are, and the reason why is because you don't want to be mistaken as police in this point to where that patient's like ultimately going to think something's wrong and try to harm you too as you move in to try to, because sometimes our uniforms aren't the best in the world. And they can be mistaken as cops. If you have these big badges on your lapel versus patches and a shirt that says EMS all over it. So, and then you got to think in that state of mind is going to be also too that you're only there to defeat them. So you have to be very cautious about that. When it says maintain an emotional difference, you have emotional distance. Keep yourself at a standpoint where you don't get emotionally attached and that you can protect yourself. Be cautious of what you see, what can possibly affect you physically and emotionally. It's draining. Dealing with emotional and mental patients are severely draining. So you have to know that in advance too, or not. There you go. Obviously, don't argue with them. Don't entertain their thought process. If they say they see zombies or people coming after them, you can just don't agree with them. Be cautious on that too. And hopefully at this point in time and being open to them that you can gain their trust, you can have a buddy. And once that buddy understands you, they will start to do more of what you ask. And then at the same time, they can be like, you know what? Nope, I'm done. And all that hard work you've put in there, it's over. Over. You can't fix that no more. Let's take a quick 10-minute break. We will be back at, let's just do 7:15. I'll see y'all back at 7:15 and we'll finish this up. Like I said, there's not a whole lot in here tonight. So see you back 10 minutes, 11 minutes. All right, so getting back to this. So let's see here. Where's the next one? All right, so excited delirium. Delirium is a condition of impairment. It's known as agitation. It's dysalgia mania. Delirium is a it's impairment of cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is a behavior characterized by restlessness and irregular physical activity. Oh, hang on. Bet. So symptoms of delirium. So you have your hyperactive irritational behavior. So you have true, very vivid hallucinogens. You think that what you see and what your mind's telling you is physically there, and it's not. It's far from. You have hypertension, tachycardia, diaphoresis, dilated pupils, and the reason why is because what you're thinking and believing and seeing is you think it's so true. You see it, you believe it, you smell it, you have all of that, the hypersensitivity that no matter what somebody tells you is it's wrong. You know it's there. You believe it. I can smell it. I can smell that the house is on fire. Well, it's far from. You're outside in the middle of the woods. So that's what you believe. That's what you know that's happening, and you delirium's rough. I've noticed that. Be calm, supportive. Empath. Be very show them care. No, it's empathetic, and I hate say empathy and empathetic and all that. So it's I changed the word. That's my wife's fussing at me because I didn't say it right. Approach the patient slowly, respect manner. When you ask them, say, "Hey, how you doing? My name's Wally, and with the ambulance service, is it all right if I can walk a little bit closer to you so I don't have to holler at you?" Try to gain that trust to begin with. If there's no answer, let your partner give that. Maybe they can approach from different, like I say approach it at 45 degrees. Maybe one's a little bit closer than the other one, or one at a time. You should probably get a better response that way. If maybe they don't answer you the first time, be like, "Hey, sir, hey, I'm over here. I don't know if you're able to, I just wanted to see if it was okay. I was a little bit closer to you so I didn't have to, feel like I was hollering at you. I don't want to be disrespectful." Obviously, we don't want to walk up and just touch them because that's not going to go well for either one of us. Never, ever, ever leave them alone. So if you have them in the back of your ambulance, don't just get up and walk out of the ambulance to go talk to somebody. Maybe the police are there because there's tons of tools and weapons in the back of the ambulance, all the way from needles to scissors to clipboards and stuff like that we have to think about. To where if they have this manic rage, that we have to be cautious. Uh, Let's say use critical interview assessments to get the cognitive function, determine the patient's ability to communicate early, observe the patient's appearance, dress, and personal hygiene. That will give you a big idea potentially of what's going on. Let you know what is going. Have they been wandering around? Are they malnutritioned? Are they homeless? Just because they appear, this person may have a manic rage and has been missing for the last 4 or 5 days, and that may be the only reason why. They may not be truly homeless, but in their personal state that you're seeing them experience has caused them to act abnormal. Yes, it is abnormal for what we're used to seeing on a day-to-day calls with EMS. Some areas do see this a lot more often, have more of a homeless, sheltered area. So when you know your area as well as y'all do, because you live in there, is to help you also build your baselines. If the patient is overdosed, taking all medications, bodily substance to the medical facility, try your best to take everything that you can. If you don't know what a substance is, don't load that substance up and go with it. It could be a hazmat scene that you're creating, that you're moving from place to place. Now that's more of a hazard. Just report, hey, there was this unknown brown substance near the patient during this. It didn't appear that there was any type of medicine bottles or anything like that reflected to be a brown substance, but I just didn't want to pack it up and get it going. Transport to the patient to the correct medical facility. Don't just take them to your local trust care, walk-in clinic, clinics on the corner, whatever you want to call them in your areas. And try to make it as easy as you can. No lights and sirens because you don't want to rile them up anymore. You want them to feel comfortable, again, relaxed, an environment so they can try to not have any more episodes on the way into the facility. Um, Obviously, we should know this by now. If the patient's condition does get worse, you do want to request that you have ALS intervention. That may be something that is automatically dispatched to where, like, if there are so many paramedics per EMS basic trucks and they sprint to certain types of calls, that may be something that you see. If not, you can request this to come to your scene because you know that due to what you see and experiencing that you're going to need ALS assistance, and ask for it. Ask for it early. Restraints. Now, so these are these are very careful. The best thing that you can see here is do exactly what your local protocols say. And if you'll notice, no matter what we teach and how we say it, you have to observe and respect what the local protocols say, because I can't teach you a way that we do it here in Mississippi and what my service goes for, and then you go to Tennessee and you try to do this. Well, that's not accepted because they may do, you know, Curlex restraint, something to that standpoint. So always know what your local service requires, and then that way that you're more able to provide a more secure route, and you don't break policies or procedures. Let's see here. Hang on one second. So restraint from a restraint from person with authority over non-emergency situation. If you expose yourself to a possible lawsuit, be careful about because you could. Some states may not recognize assault or battery. You have to figure out what your states do, and then you are right here. You are false imprisonment. You're keeping that patient from leaving. You are not allowing them to get up and leave if they want to. You are restraining them. You are, some law enforcement agencies may not allow their officers to intervene when you are trying to restrain a patient, even though you have medical orders, because it's a liability. It's very it's picky. Some places just don't. I try to throw it away. Don't allow it. So you may not get assistance from law enforcement unless it is relayed to them that you can have law enforcement assistance. And when you're ready to restrain, make sure that you use one person on each limb. So you have, and when you be prepared to restrain them and be ready to restrain them, have them on one person per arm, one person per leg, and then be careful at the same time as you may have somebody want to hold the head. If so, the head controls the movement of the body. If the body wants to go left, the head's going to go left too. It's hard to get up and move, especially with someone like we can put our heads to the right and move our bodies to the left. That's fine. We can do that. But when somebody's in a delirium standpoint and they're trying to do things, they don't think that. They put their heads. So if you can hold their head against the stretcher while their body is being restrained at the same time, be cautious for that because it keeps them from, like, they can't bite you or spit on you. So be careful of that too. Not working. So involve law enforcement if the patient has a severe behavioral crisis. Again, I just told you some agencies don't allow that, so you be cautious there. Before considering physical restraints, use verbal de-escalation techniques. Again, try with your basic and work with your advanced. And we want to say, sir, listen, I really don't want to have to try to get some assistance out here. I don't want to have to physically restrain you, but I need you to work with me. Is there any way that we can work on this and we can work this out? You give me something, I'll give you something, and we can go from there. But if you have to and you have to physically restrain them, that's fine. But get your game plan together. Make sure you know what you're going to do. And when you react quickly. Like it says there, at least have 5 people, four, 5 is optimal. 4 is probably what you're going to get in some standpoints. Make sure that one person is your captain of the team, that they're calling the shots. That if they're not, okay, then you have your next one that's going to step up because maybe that person, is affected in some more fashion. They may have their hands, full with that particular part of the body and they don't want to let it go. And then they completely forget what's going on. So you don't want to explode with max force on everybody because it's called de-escalation techniques. And then when you escalate it. So if you come at me with a fist, I can go at you with a non-lethal weapon. Well, if you come at me with a bat, I can go at you with a lethal weapon. So you can always take one level higher, and then that's it. So basically, if they're hand to hand, you're going at them just the same force. But for law enforcement, they can go one level higher, and that's where you get the hand to non-lethal, the non-lethal to a gun. So those are some of the techniques that you have to do and think about. But quickly, the best thing that you can get right here is carry out the decision out quickly. And 5 is the biggest number that you want. And you can have as many people as you want, to be honest, but you want to move quickly and make sure that you have one person on the extremities and they know their jobs. They know what they're trying to do and they know what they're going to carry out. As I want people to know your jobs and to move forth and not to be like, oh, I don't know what we're doing. So remember that. So level of force vary depending on these factors. The patient's size, sex, strength, and mental status. If they're a bodybuilder, you might need a little bit more than 5 people. The degree of force is necessary to keep the patient injuring themselves. So we may try to attack them with 6 people, and it's because we want to make it quick, and so it doesn't allow that patient to harm themselves or others in a timely manner. That's right. So the type of abnormal behavior is the patient exhibiting. Is this normal for this particular patient, or is it something out of the normal, out of the the standards? Is this an acute issue that's affecting them, or is this something that is a chronic behavior? Those are things that we just need to know, because when you talk about restraints, guess what? If it's like this is normal, they've been restrained more than one time, I can promise you. Well, guess what? They know your game plan. So they may flip it on you. And when you go to attack them, they may draw their arms to look like one pole instead of their arms and legs flexed out. Now you're like, oh God, I don't know what to do. So you got to be ready. So knowing their behavior standpoint is something that's important because we need to know what we're doing there. Talk to the patient through the process. Well, that's if you can. You may have your hands full, but again, we still have to treat these patients like they somebody's kid, they somebody's mother or father. They're just not an end. I mean, they're not just a subject. We want to respect them, and when it's over, like, sir, I'm so sorry we had to do this. Please understand why we're trying to get you help. I'm sorry we've had to restrain you. Is there anything I can do for you right this moment? And they're like, always, untie me. Well, I can't help you do that, but is there anything else? We said right here's if possible, a provider of the same gender should attend to the patient. And that's just for the comfort level, and for safety too. It's always safer to have, if the female is restrained on the stretcher, to have a female attendant, so they can't say that sexual assault or anything like that occurred while you're in a facility. I believe in body cameras. I know that they have their place in EMS or they don't have their place in EMS. but I just believe in them. It provides an extra ability for safety. I think it is safer to have them. I do believe in onboard cameras and audio. It is not an invasion of privacy because you know that working for a company, you may not feel comfortable at it, but it's an insurance policy for that company. Now, how they start using that data, like if you're sitting there talking about some BS policy that just came out and they use that against you, that's considered invasion of privacy. You just have to be cautious or just exit the vehicle and vent when you're stopped at a posting stop. So those are some of the things that may have to be addressed also when you go through these policies, but I just believe in, body cameras. I think it's important. When you're going after these patients to restrain them, be cautious. Again, if they're restrained, don't leave them unattended. Um, I know when I was talking about eye contact because that's the sign of aggression. If I stare you in the eyes and we're not just having a general conversation, I can show you. That's the same thing as the animal world. They show dominancy by eye contact, and whoever looks away is a coward in the animal world. But so you have to be cautious because you're trying to restrain somebody that's already having a mental crisis, and now you're challenging them by making eye to eye contact after you've restrained them. So you have to be careful there. And when it talks about 4-point restraints, make sure both arms and both legs are preferred. And I've always used soft restraints, no matter if I just had to use Curlex or the padded shackles. So that's what we've always carried in the ambulance and services that I've worked for. I mean, I've had to make Curlex work to where it's a physical restraint, and I have tied some people down in some weird ways. It's just when you get them into the hospital, people look at you and be like, you know what, bro, that's how it works. I've transported patients with their head on the feet and one leg tied to the side of the stretcher, the other leg tied to the head of the stretcher. You know what, man? You weren't there, so when you cut them off, be careful. Reginald, I know you. I mean, you work up in the Memphis area. I mean, you guys. I mean, I've been up there. There's some crazy folks. You know what I'm talking about. You just do what you gotta do. When you put somebody down, that's exactly. I'm gonna say yes to your statement. I'm gonna just only say yes. Anytime that you restrain somebody, anytime you have to make sure that you assess them all the time, because at that point you are that patient's sole carer. If something happens to them with you restraining them, you're at fault. So if their airway gets blocked, or they do vomit, their respiratory status does change, it's all on you. Respiratory and circulatory problems have been known to occur in combative patients who are restrained because they're so worked up with being anger that something happens. Look at this shoulder dislocation. That's perfect because they're fighting to move their body and their arms are tied and they apply so much strength it just pulls that socket out. So be cautious of that. Be ready for that situation to happen. Yes, you're sitting there trying to be like, oh my God, I can't believe that's what we just had to do, but I can't breathe. So but be careful, be very careful to not take your eyes off of them. And at the same point is watch out for them to spit. I always try to put a non-rebreather on the patient, and you do turn them on. Not that is totally disrespectful if you don't turn it on, but I've seen it happen. But apply oxygen to them. Put their, because what it does is it keeps them from spitting. Spitting is the whole point of putting that on. Violent patients account for a small percentage. In about 20 years, I've probably restrained less than 15 people, and that's I'm gonna say 20 people total, and that would be chemical and physical restraints. And I mean that's it seems like a number, but in 20 years, that's not a real big number that you deal with. A lot of people can be rationalized and talk to them rationally, and you can calm them down and be like, hey, listen, I don't want to do this, but if we can't work out a deal, this is what's going to have to happen. I'm going to have to restrain you, and they don't like that. And as you're building your history, again, ask if there's bystanders around. Is this something that knows the patient? Is this something that happens on the regular? Or is this rare for this patient to act like this? When's the last time that this patient has responded this way? Can you provide me some information? And then most of the time, people are willing to give pass that information on because it's just as shocking to them it is to you because they're not used to that. But know that you may not get the information you're looking for. They may just not know. They may have just witnessed it. Here, check for, always look at their hands. Always look at their hands when you're dealing with somebody. If you want to know what way a patient's going to turn or the way they're going to jump, look at their waist. Their waist will always dictate which way they're going to go. Vocal activity. Is this patient even speaking? Are they responding? Are they giving any idea of what's going on? Or are they just very bizarre? It's like just everything's just not normal. Are they loud? Are they quiet? Are they strip butt naked and it's like 4 degrees outside? That's just not normal. That is very erratic behavior. Maybe it's a drug. Maybe something that they've taken has caused that. So those are all things that you want to note when you're getting ready to do this. Physical activity. Most telling factor a patient is requiring careful watch is one of the two. Has tense muscles, clenched fists, glaring eyes. What this tells you right here is that they're ready to jump. They're ready to go. Clenched fist means they're going to attack something. They're going to punch. So they have that rage. The glaring eyes. It's not only is it the, like we say in a seizure, the 100-yard stare, but this right there just means like they are not who they normally are. They are not acting normally. If they're doing the pacing, they're walking back and forth, or doing that rock, and they're just constantly rocking, and they're staring through you with those glaring eyes, be very cautious. Something's going to happen. Do not interfere with their personal space. If you see this above here, do not try to even walk up. Talk to them from a distance and say, what can I do to help you? Let's work through this. If they don't respond to you and you just hear, buddy, you better call for some help. You better get you some assistance. And you know what? Game on, because it is going to get rough shortly. I can promise you. It's just not going to be fun. Some of the other activities here, ow, sorry, I'm getting old. Had a little arm injury there. So history. So it's the cops may know, be like, oh yeah, fighting Fred's ready. It's Friday night. He got his money. It's time to get a check. He's ready to get that liquor in him. He's gonna do good. You may just notice the patient's depressed and they're gonna try to agitate you or provoke something to happen because they just don't know. They think this is it. Substance abuse, man. Unfortunately, with EMS, you're gonna know all your substance abusers, if they're heavy abusers, within the first 6 months of working out there. You're gonna know majority of them because you're gonna at least deal with half of them. I mean, if the patient tells you voices are telling him to do something or harm someone, they have the HISI ideations. Be prepared and believe them. Don't question it. Don't be like, well, what are they telling you to do? Just believe them, because you probably don't want to hear what those voices are telling you or telling them to do, because it is probably it's probably going to be very graphic, and it's going to be very just not what you want to hear. So just say okay and rock on with it. So suicide is well, I have some personal friends that have dealt with suicide. They obviously completed their mission, unfortunately. I've had some that have attempted it. I've responded to some people that I know that have attempted it, and weren't successful. It's hard. It's telling, no matter what, if you don't know them or not, it's very hard to deal with. It is a misconception that people who threaten suicide never commit, because that's not true. Right here, they are crying for help, y'all. They need assistance. They need your help, and they need an immediate intervention. If they can get that, they have chances of moving forward and trying to get past this very dark moment of their life. If they're trying suicide, they don't know what else. They feel alone. They're loners. They're out there. They're scared. They're just they need help. Be alert for signs. Feeling of sadness, deep despair, appearing detached from the situation, an inability to talk about the future because they don't see anything past the next 5 seconds, because in the next 5 seconds they're going to do it. If they suggest suicide as a joke, or it'd just be better off if I wasn't here, and if I kill myself, y'all would be fine. Well, that may be an anger and rage, but they're talking about it, they're hinting it. And if they say, if y'all come any closer, I'm gonna kill myself. Well, they may say, well, I'm gonna harm myself. I really wasn't saying that. Y'all misunderstood what I said. No, because now at that point, they've made that statement clear. They have to go to a medical facility, period. No question. They can't go to jail. They have to go to get treated. If you see notes, plans, they've said, well, I've thought about it really heavy. If I ever die, y'all better know that it's been thought about. You're like, whoa, what did you just say, bro? They put some thought into this. There's some risk factors, table 223-3, that tells you things that they have thought, they've dealt with. They say there's a particular group, age, and sex that have more ideas and thoughts of suicide than the others. Don't remember that, but I know that there's been a big study about it that can tell you the groups and ages. Other is things unsafe that's near you? What about the environment? What is there to harm me? Maybe that was a homicidal, suicidal plan, and as you're going in there to try to render aid, something else would happen. It would kill you also, or other responders, and that was their plan to begin with, and you just didn't know because you had the tunnel vision. Be careful. Do we see imminent threat to the patient, to us? Well, I'm worried about me, to be honest. That I hate to say it, they can do what they want to themselves. If they at that point, just don't come after me. I'm cool. But no matter what, I'm here to assist them, and I'm going to give that patient the utmost care when I come to take care of them. I'm going to make sure no matter what happens, I'm going to try to fix their problem. And if that means fixing it is getting them to the best medical facility, then that's what I'm going to do. I'm going to make sure I do that, and we're going to give them the care. Again, like I said right there about them, a suicidal patient may be homicidal because they want to see and physically deal with homicide. Would you go get Charlie's cat? As a coach, you're also religious beliefs in promoting suicide because they feel like that is the utmost thing for them to get to their best religion in certain land or thoughts and prayer. That's their way. I don't know about the trauma standpoint, but a lot of folks is an underlying medical problem. I know that a lot of the elderly, they feel like they're a hinder on some people, a hinder on family, and that both of the couples may say that they may plan it out together. They may kill each other and through love, and they don't want to, make families suffer and have to take care of them in their dying times, or if they've been diagnosed with terminally ill disease and they still have their brains, their thought processes themselves. Can y'all hear me? My headphones just messed up on me real quick. I just want to make sure.
Yes.
Okay. All right. I don't know. I think my computer just needs to be reset. I think she's tired. So here we go again. Post-traumatic stress disorders are reoccurring combat veterans. We know that. Some of the examples of PTSD: sexual assault, child abuse, serious accidents. So again, I feel like that PTSD is an overused term. As we can tell, we've all talked about this. I don't display that any of the issues are there. I truly believe that all these, where my cursor went, that all these are truly traumatic disorders. Those have got to be a traumatic event. I don't want to say disorder. I truly do. But I think the broadness used of PTSD is the problem. But those all fall into the PTSD category. Post-traumatic stress disorder and reoccurring combat veterans, that is natural. They say natural disasters cause it. Obviously, we know war. I don't know how you get loss of a loved one PTSD, because it's most of the time PTSD is from a reoccurring situation or a stressful life changes. I don't want to feel like I'm giving my personal and opinions about all this all the time. Those are just examples of events. How about that? I'll just leave it just like that. So not necessarily the results of an isolated event. An estimated 7 to 8% of general population will experience signs of PTSD at some point. There goes back to my statement. Military persons who have experienced combat and have incidents of PTSD. If I'm not mistaken, combat medics that went to Afghanistan were one of the highest categories of individuals that committed suicide for years, because they saw combat all the time and lost the people that they tried to take care of all the time. So here's some signs and symptoms of PTSD: helplessness, anxiety, anger, and fear. I will say yes on that. If you're done, throw it away. If that's something that you're going to see, all of those have issues there. I mean, obviously we all have anger. At some point, things anger us all differently. Anxiety depends on which level of anxiety you have. Maybe certain things increase your anxiety. I personally have one that is I despise cluster and clutter. That increases my anxiety. I get very, very bitter, shall I say. So I'm one of those like I want to fix it and fix it right now, and everybody's gonna stop and we're gonna fix this. So, but depends on what part of anxiety they refer to on PTSD. People with PTSD potentially frequently avoid things that remind them of the trauma. They suffer from constant nervous system arousal that is not easily suppressed. Their heart rates increase, the pupils dilate, the systolic blood pressure increases. Senses are sharpened and their mentally activity is heightened. Often relieve the traumatic event through instructive thoughts, nightmares, and events of flashback. Dissociated PTSD occurs when the person attempts to find an escape from constant internal distress or particular disturbing event. I think PTSD animals or service dogs are the best. Again, I want my monkey. Whenever I get my monkey, y'all gonna see it. That's gonna be that guy on social media that tries to get thrown out of a store because of my monkey. He's flinging poo. So I'm telling you, it's coming one day. But I truly believe in these. These animals are so well that they recognize these and they help people deal with that on a daily, minute, hourly basis. Let's see, alcohol and drugs are common use. Veterans have an increased risk of suicide. Veterans may develop a variety of physical conditions related to inquiries sustained during combat. Veterans have higher incidence of TPIs sustained to trauma secondary explosions or improvised explosion devices. IEDs suck. They are real. They're there to cause harm. Eliminate excessive noise. Refrain from touching or doing anything to the veteran without explanation. The diesel equipment, the smell, radio traffic, that break in the radio are also triggers. You want to, if you have to, you want to try to, if you know that is an event, tell your fire guys, hey guys, can you shut your engines off? We're going to shut our diesel engine off. These are some triggers. The smell of the diesel. And when you go to get the patient in the ambulance, be like, sir, listen to me. We're going to crank this truck. It is a diesel motor. I want you to be prepared for that. Don't do something that you potentially know is a trigger without informing them, because they are, if they can expect it, the better off that they'll be. Caring for combat vets, be careful how you phrase a lot of things. The way that you may see questions asked, it's not the way it's going to be it's taken, because they're not prepared. You want to use a calm, firm voice, but be in charge. Don't allow them to take charge. Don't allow them to change what you say to put in their standpoint. You be the center, be the person that's going to run the show. Respect their space. Always know that they can harm you. They are very well trained in hand-to-hand combat. Don't allow them that distance. You want to be able to stand greater than 6 feet. If you've ever watched the gun versus knife show, that a person with a knife can close a gap of 6 feet or less faster than an officer can draw his weapon from his holster. So they can cause harm. I mean, if you know the person has a potential dangerous weapon, keep your distance greater than 6 feet. It should help you. It's not going to save you if that's what they want, but be cautious of that. And ask those questions. Be careful about those questions that you ask, but you need to know, do they have suicidal ideations? Do they believe that they're going to do it, and what means? Sir, understand that we're here to take care of you. Can you tell me what's going on? Have you had bad thoughts? Have you thought about harming yourself and or others? I ask these questions because I want you to be prepared that they're going to be asked. So if I can get these answers, I can help you divert that. Now, they're still going to ask the questions, but I want to know, be like, bro, is this dude going to try to hurt me? What's his thought process? I need to know these things. And so there's nothing in the patient's access. Well, obviously, we want to keep their hands clear. We don't want them to be things to us to grab, or we want that to be clear. When you get ready to physically restrain them, be prepared, because that might, well, it's probably going to make things a lot worse. So you knowing that on the front end may prevent you from trying to tie them down, because that is a fear. That is something that's going to trigger a reaction. And if you're not prepared, it's going to be a reaction that will surprise you. You must decide whether the patient, once you have determined that the patient has impaired mental capacity, you must decide whether he or she requires immediate care, or is it something that you can sit there and delay? A patient's mental status is unstable, may resist you to attempt to provide care. Do not leave the patient alone, and request law enforcement personnel to handle the patient. Again, I've told you that can be also a touchy subject as we talk about that. Implied consent is assumed in this point, as long as they're mentally unstable. If they are stable and they're able to comprehend what's going on, you need to get them to give you permission to take care of them. You need to ask permission. You need to receive yes, no, maybe, I don't know, before you go off and try to assess them. and put your hands on them because it may not turn out well. What is your legal authority? The EMT has no legal authority to require or force a patient to undergo care when no life-threatening emergency exists. If they tell you, no, I don't want you to touch me, there ain't shit you can do, folks. If they are mentally incapable of answering that, then at any point you can still call med control for assistance, but know that they may tell you, yeah, I'm fine with him staying there. It seems like it's going to be a harder deal. Law enforcement can get involved and then they can put the person on a hold, but we can't do that. I'm not going to jail for nobody. I look good in orange. I personally think I do, but I don't look good in orange jumpsuits or the red and white candy stripe ones. They just don't look good on me. I don't think it goes with my color, so I don't want to wear none of those. So be cautious how you forcefully restrain somebody. You got to be careful. A psychiatric case is a court of law would probably consider your actions of providing life-saving care to be appropriate. A patient who is any way impaired may not be considered incompetent. You always maintain a high index of suspicion regarding the patient's condition. Assume the worst and hope for the best. Err on the side of treatment and transport, and carefully document the patient's status and behavior to support your actions. This is what the patient presented. This is what we did. This is what was answered when a patient was asked this. Patient was asked clearly, do you have suicidal or homicidal ideas? If yes, patient, med control was approached at this time for such and such orders. And I hope y'all understand that when I say document is the most important, I hope y'all understand document is super important, that you all document that very carefully when it's time to deal with a patient. You have to be very cautious about it because it can come back and bite you in the butt if you don't do it correctly. I just want y'all to know that documentation is your friend. Don't be scared of it, but at the same time as you have to document correctly and fully. Don't just pretend and don't write just enough to get you by. No, you need to be documenting on everything, and even on reports that's not yours. If you're just a basic on a paramedic truck, that's fine. Ask your partner, be like, hey, listen, I'm trying to build my resource and my knowledge part. Is there a chance that I can write a report on my, let's say, my phone? Would you have any problem in reading it to see how well I'm doing, or if I'm off, or can you help me out? Teach me something and allow me to grow with it. That's the end of the chapter for tonight. Is there any questions, concerns, or problems that you guys have about this chapter? Or y'all want to add anything that maybe we can go over? Or do you have anything that y'all have done that can help by telling us what we can grow off of?
I'm just saying that I've dealt with multiple dogs when it comes to police dogs and seeing eye dogs and dogs that are there for people with like PTSD or any kind of disorders. And it really is neat how they respond. And even people like with seizures and things like that. And how the dogs just know. And then the client will tell you, what the dog is thinking and what it's looking for, and its actions and its behavior and stuff. And then they kind of alert you and tell you this is why they're doing that.
And respect that dog, and I know that the working vest, respect that vest. Give them their space, and then the dog can come and sit beside you, but you just can't reach down and touch it. It's the most I know about the dogs. But once that dog gets the vest off, they are like, but it is game on. I know that
Yes,
the ones
exactly.
I've dealt with. So, but that's all I know. And I mean, like that is it's a great information, and having the ability to work with these animals at the same time is just as rewarding as trying to take care. And also, if you take care of a patient that has an animal, that animal has to go to the hospital with them. No hospital is going to tell you no. So know that in advance too. Anybody else? Are we good? Come on, LSU. I know you good. I'm listening.
I was just gonna say from my experiences too, we've had to deal with vets before, and it's just, at times their families try to hold on to like sanity and just overall the grief and everything that they deal with, because at times it can be anything from just PTSD to them attempting suicide, and it's just, you're not there for the moment, but like as soon as you're dealing with them, you see so much emotion and everything just flusters the situation. And just one of the biggest things that seems important to me, at least, or from the cases that we've done, is just being able to maintain like a calm and steady mind, because what they need is reassurance more than anything in these severe cases. So as long as you can give them like a straightforward answer, like, hey, my name is this, we're here to help you, and that's all we want to do, just seems to help out the situation 10,000 times more than being scared or yelling or any kind of offhanded reaction.
Yeah, and the people are gonna know. We know when somebody's lying to us, and the same thing as a patient knows. Just don't lie. If they ask you a question, be like, you know what, brother, I don't know, but we're gonna find out together. It's cool for that. There's no problem with just saying I don't know. You know, guys, and guys and gals, sorry. It's been a this is a this is a touchy topic because I also talk about like personal. How do we take care of ourselves? That's a whole nother topic we'll go into here, but you'll lead off of this too. Some of y'all want this for tonight. That is your look at that smile. See, I knew what the man was wanting. So that's your class code for the night. Please make your notes, your stuff. Good luck to you on all your tests. Just to let you all know, I know I should have told you this prior. I see here people already dropping out. I will be out of town this weekend. I will not be reached by phone, email, or anything. I'm taking some family time, and we're going out of town. So if you need anything, please post in Discord. Rob will know that I will be out of touch, and we will help you guys out. They will help you out as much as possible. Rob and Brandon will be there to help you all out. Good luck with y'all on y'all's test, and there's your class code. On to Tuesday night. We will see y'all then. Please have a great and safe weekend, and hotty toddy, and go eat some corn dogs. LSU. Y'all have a good one now.
Take that hotty toddy off that.
Y'all be safe. We'll talk to y'all Tuesday.
All right, man. Take it easy.
All right.